Good morning. My name is Heidi Phillips, and I'm an associate professor of small animal surgery at the University of Illinois. I and my student, G. Park, who has just started her rotating internship at Red Bank Animal Hospital, have worked together on this case series and abstract that I am about to present to you, titled Treatment of Laryngeal Webs in 4 Dogs Using Endoscopic-Assisted Diode Laser Resection and Topical Application of Mitomycin C. I'm going to go ahead and share my screen. We have no conflicts of interest to report. So, to begin, laryngeal webs are described in people, dogs, and other species and can be congenital or acquired, and are most commonly of the acquired variety in dogs. When acquired, they occur secondary to some kind of laryngeal mucosal injury, be it from cervical trauma, say for example a bite wound to the neck, or iatrogenic surgical injury, long-term oropharyngeal intubation, or severe infection. Of these, iatrogenic surgical injury appears to be the most common cause in dogs, according to the previous literature, and this proved to be consistent in our case series. The mucosal damage and web formation result in airway obstruction and associated clinical signs. Clinical signs reported in the past or that might be expected to result from laryngeal webs or glottic stenosis include exercise and heat intolerance, lethargy, stridor, some degree of dyspnea or tachypnea, gagging or coughing, and in severe cases, collapse. Now, I mentioned iatrogenic surgical injury was the most common cause, and although procedures such as laryngeal sacculectomy or retinoidectomy involve potential trauma to the vocal cords, the most commonly reported cause of laryngeal webbing is ventriculocordectomy, or the quote-unquote debarking procedure. The mucosal defect is most often not sutured, especially when created from an oral approach, and is allowed to heal by second intention. If the defect is inadvertently made too close to the base of the vocal cords and the base of the glottic opening, the defect permits contact between bilateral cut surfaces. As the larynx continues to abduct with each inspiratory phase of respiration, healing of the areas of traumatized mucosal tissue in contact with each other occurs in such a way as to try to stabilize the wounded area that is in motion, resulting in significant fibrous tissue deposition. As debarking is presently considered unethical by many veterinarians, it is difficult to find images of the various forms of the procedure. However, this veterinary clinic in Singapore advertises their veterinarians will perform the procedure only in cases where dogs would otherwise be euthanized, and offers photos of both the intraoral and ventral laryngotomy procedures. Because there is limited room to permit suturing of the mucosal defect via the intraoral route, it is the intraoral procedure that is most likely to result in laryngeal webbing. Since the ventral laryngotomy procedure does permit apposition of the laryngeal mucosa, this procedure would be expected to less commonly result in laryngeal webbing. We'll discuss a bit later how we came to use mitomycin in our cases, but as an introduction, mitomycin C is a chemotherapy agent that disrupts base pairing of DNA, inhibiting RNA and protein synthesis and the proliferation of fibroblasts, thereby offering potential as a preventive measure for development of scar tissue or stenosis in susceptible tissues. The use of mitomycin C for this purpose has been reported in cases of laryngeal, ocular, and urethral surgery or injury in both people and dogs. The objective of our study was to describe the presenting clinical signs, physical examination findings, laryngoscopic findings, and clinical outcomes of dogs with laryngeal webs treated with diode laser resection and topical application of mitomycin C. Our study design was that of a clinical case series. And 4 client-owned dogs were included, 3 male, 1 intact and 2 castrated, and 1 spayed female dog with a mean age of 8.5 years. We had a 6-year-old male intact Finnish Lapphund, a 7-year-old castrated male smooth fox terrier, a 9-year-old castrated male Shetland sheepdog, and an 11-year-old spayed female Maltipoo. Historical and presenting clinical signs included chronic respiratory noise, identified by the owners as a high-pitched wheezing sound, worsened by heat, exercise, or excitement in all dogs, and noted from the time of adoption. All of these dogs had undergone debarking procedures in the care of their previous owners prior to being relinquished and subsequently rescued into their current homes. The degree of stridor was reported by owners to vary, but appeared mild and intermittent on exam in all dogs. The most apparent and consistent finding among our dogs was exercise intolerance. Every owner reported that the dog was less active than expected, did not tolerate hikes or agility training, and so forth. On physical examination, there were no remarkable findings outside of the respiratory system. All dogs exhibited mildly stridorous breathing, able to be heard without auscultation, but definitively auscultated over the larynx. Dogs also occasionally exhibited an expiratory wheeze or gagged. On sedated oral examination and laryngoscopic examination prior to intubation or after intubation, all dogs had a thick, fibrous appearing web spanning the ventral glottis and including 50 to 70% of the glottic area. The web is readily seen here. Here we go, here and here, as well as here in this intubated dog. Here, in this intubated dog, the endotracheal tube was wrapped with foil to prevent inadvertent lasering of the tube and ignition of oxygen. An anesthetic gas mixer was also used to limit oxygen concentration and prevent fire. Later, our anesthetic team did use copper tape around the endotracheal tubes. Resection of the web was accomplished carefully using a 2.7 millimeter 30-degree endoscope, a diode laser in continuous mode, and a 400 nanometer laser fiber. Initially, in the first procedure, we simply split the web from dorsal to ventral without any resection of the resultant flaps. In subsequent cases, we resected an inverted triangle-shaped portion of the web and submitted the tissue for histopathological examination. Here is a video of lasering of the web in progress. You can see mucus accumulates rostral to the web, and the web is very tough and fibrous. In subsequent images in this presentation, you'll see the web is also very thick and a rostral to caudal orientation, requiring patience and care to traverse its depth and remove the tissue as completely as possible without causing harm, and restoring the glottic opening as much as possible. This video shows what the area looks like immediately post-lasering. You can see the laser leaves a bit of carbon on the tissue, and that tissue sloughs over time and is replaced by new mucosal epithelium. You can also see how completely the web tissue was able to be removed with this approach. Dogs recovered uneventfully from anesthesia and for 1 to 2 days in the ICU before being discharged. Gastrointestinal protectants were variably used to prevent or mitigate issues expected with gastroesophageal reflux, regurgitation, or aspiration. However, none of these complications occurred. Here are some of our procedural data. The image here is one of our brachycephalic patients, not a laryngeal web patient, but shows how the dogs are positioned in a maxillary sling to permit laryngoscopic interventions, and you can also see the copper tape covering the endotracheal tube. A total of 4 dogs underwent 6 procedures. Mean surgery time of all procedures was 92.5 minutes with a range of 70 to 132 minutes. Mean anesthesia time was 129 minutes with a range of 100 to 170 minutes. Histopathology of the excised tissue was consistent with a laryngeal web in every case. Tissues were characterized by regions of dense fibrous connective tissue consisting of fibrocollagen bundles, sometimes with skeletal muscle, and showing no evidence of inflammation or malignancy. Following discharge, recheck examinations were scheduled at 2 weeks and 6 weeks postoperative. 2 dogs continued recovering uneventfully, while 2 dogs developed partial or complete recurrence of the laryngeal web at 5 and 8 weeks postoperative. No other complications developed in any dog. This is Toby, our first case in which we only transected the web from top to bottom without resecting any tissue. His clinical signs returned, and he was diagnosed with recurrence of laryngeal webbing 5 weeks postoperative. You can see in the video how the flaps have more loosely formed into a web again. We began using mitomycin as a result of this recurrence and during Toby's second procedure. When applying the mitomycin, a 5-minute application is administered to each area of the excision. Multiple applications may be needed to ensure coverage of the entire area of excision. Now this is Nick, whose clinical signs returned and who was diagnosed with a recurrence of laryngeal webbing at 8 weeks postoperatively. What's interesting about Nick is his recurrence developed despite removal of a segment of the web and in the face of treatment at the first surgery with mitomycin. So following his second excision, we applied mitomycin twice, immediately after the lasering and again 24 hours later under sedation. He subsequently did not develop another recurrence. Here we show follow-up endoscopy photos 2 weeks after the first or second procedures. The images on the left were obtained following the second procedure in the 2 dogs that developed recurrence. The images on the right are of the 2 dogs that did not develop recurrence. And here in the video, we can see that the ventral glottis in Toby is now clear and permits further opening of the glottis on inspiration. All dogs were doing well without clinical or endoscopic evidence of recurrence at 3 and 6 month follow-up intervals. The exercise intolerance had greatly improved and all dogs were able to run, jump, play, or hike, or engage in agility training without difficulty. Additionally, the mildly stridorous noise apparent to the owners preoperatively was no longer heard in any dog. Owners rated the procedure a mean of 4.75 points on a scale of 1 to 5, with 1 being completely unsuccessful and 5 being completely successful. We were able to find only 2 publications in the veterinary literature discussing restriction of glottic opening after devocalization procedures, the first from 1994 and another from 2008. In the 1994 paper, glottic stenosis was diagnosed in 9 dogs following debarking procedures. Dogs were treated with scar excision and corticosteroid therapy. In the 2008 paper, dogs were treated by ventral laryngotomy, resection of the web, and mucosal apposition of the remaining tissues. Dogs had fair to excellent outcomes in these studies, but underwent more invasive procedures. In our case series, we found that dogs treated by endoscopic-assisted diode laser excision of laryngeal webs, followed by topical application of mitomycin C, fared well with a minimally invasive procedure that we found fairly effective. However, it should be noted that more than 1 procedure may be required. Despite this, we'd like to be able to reasonably conclude from this very small cohort that the combination of surgical excision of the web and the topical application of mitomycin C may be more effective than surgical excision alone in preventing recurrence of laryngeal webbing following devocalization. However, it's likely that more cases are needed. And here would be our topical application of mitomycin. Finally, we should note that no dog showed signs of respiratory distress, cyanosis, or collapse despite significant glottic obstruction. Therefore, veterinarians should evaluate for laryngeal webbing in any dog with a history of devocalization that shows signs of exercise intolerance and inspiratory stridor. And with that, I, along with Toby, Squirt, Nick, and Snow, thank you for your attention and be happy to receive any questions. Because I am unable to present at the conference in person, please feel free to send any questions to my email at philli@illinois.edu. Thank you so much again.